everybody. So this is a subject which is largely in the realm of surgeon. So to oppose a surgeon and get away with it is not a very easy task. But I think the winds are blowing in a different direction. We'll talk about pancreatic ductal adenocarcinoma, and I'll vouch for chemotherapy first. In fact, I will vouch for neoadjuvant therapy first rather than neoadjuvant chemotherapy because there is an upcoming role of radiation, and we do have a lot of vocal radiation oncologists in the field. So the biggest problem of pancreatic ductal adenocarcinoma is not the left-sided resectable carcinoma. The biggest problem of pancreatic adenocarcinoma is that almost 50% of our patients are metastatic at presentation. Even if you were, so even if you were to look at the right two things, that's the right two slides, that is also in fact a very big problem. More often than not, the disease is irresectable or unresectable or is borderline resectable. And in these two situations, the management modality is more or less kind of sorted. What are we going to do to them? A small minority of patients are resectable. That's the point of discussion today. So that's in fact the biggest problem, that most of the patients cannot undergo surgery for the way they present, because that's how this disease is. If I was to sum up this debate, then I would say it's not the sequence of therapy which is important. What is important is that the patient should receive all treatment. So there are largely three modalities of treatment, largely speaking. One is surgery, second is chemotherapy, and third is potentially radiation therapy. So what the issue is, the patient should be able to achieve both, should be able to receive surgery, should be able to receive chemotherapy, and very soon the role of radiation will be defined, and I believe the patient should receive radiation once the role of radiation therapy is more clearly crystallized. So what are the pros and cons of surgery first and neoadjuvant therapy first? And a lot of answers on this debate from my side will be from this slide. Surgery is a traditional way of treating the patient. It is backed up by multiple randomized trials. But the problem, as will be apparent in the subsequent slides also, is that a large number of patients do not receive adjuvant therapy. And this is critically important, that the patient should receive adjuvant chemotherapy, but they do not receive adjuvant chemotherapy. It is extremely difficult to administer adjuvant treatment or adjuvant chemotherapy post-Whipple's, even 2 or 3 months after this large big surgery. Often we find that the patients are documented to have metastasis intraoperatively during laparotomy when they have small occult peritoneal mets and hepatic mets. So it happens quite often, either on diagnostic laparoscopy or laparotomy. We have clear evidence that while the patient are waiting for adjuvant treatment, some proportion of patients relapses within the next 2 to 3 months while they're waiting for adjuvant chemotherapy. We have models and evidences that pancreatic carcinoma is a systemic disease, which is evidenced by the fact that if the patient do not receive adjuvant chemotherapy, then the relapse rate in resected pancreatic cancer is approximately 90%. So that means more or less this disease is metastatic to begin with, and therefore we are treating a metastatic disease. That should be kept into consideration. On the other hand, neoadjuvant therapy potentially allows this treatment, which cannot be offered in an adjuvant fashion, to more patients, because these patients could be fitter provided that biliary drainage is done. Theoretically, we treat the micrometastasis, which becomes apparent during the surgery or immediately post-surgery before they have the chance to become macrometastasis. We can choose a good biology or a bad biology, and a bad biology tumors could show themselves up, and therefore you can avoid an unnecessary surgery. We have evidence that there are higher R0 resection rate, not necessarily resection rates. They have lower lymph node positivity, lower margin positivity. The concern for the last window for surgery can be overridden by the fact that possibly we're selecting bad patients and letting them show up during chemotherapy rather than going for an unfortunately unnecessary surgery. Yes, there is a need for biliary drainage, which is important, as most of these patients have jaundice at presentation, and there's a need for biopsy, which often is not required for, or more often not required for the surgery. And the surgery and the biopsy is not always an easy job. So this is a guideline from 2021, but the 2022 guidelines are absolutely bang similar. You could either go to surgery, which is the level 1 evidence, but it clearly, and the other guidelines like European guidelines suggest that consider neoadjuvant therapy. To to reiterate, there are problems with surgery, there is morbidity, there is complication rate, although a good surgeon and an institute which performs Whipples regularly is able to handle that much better, and a good surgeon and a good institute is a good prognostic feature for the patient. But despite that, there is a morbidity and I think very less mortality. This graph kind of summarizes the thing. This is John Hopkins data and this is old data, and at that time at maximum gemcitabine was being used. So the orange or the red color curve is the patient who has been operated and has had complication and did not receive any adjuvant therapy. You look at data set and there is a median survival of 10.7 months. At this point of time, average survival of a metastatic pancreatic cancer is more than 10.7 months. Obviously the times are different, but you could see that if you don't receive adjuvant therapy, which means chemotherapy does a lot, you would end up like a metastatic carcinoma, whereas patients who haven't had significant complication and managed to get adjuvant therapy, there is a doubling of overall survival in the same time period. Is there any evidence that inability to complete the chemotherapy? There is evidence from the current trial. These are all new trials. PRODIGE 24 is the latest trial. Look at the single agent gemcitabine. In the current era, you can't deliver adjuvant chemotherapy to about 30% to 40% of population. You're missing them directly. If you look at FOLFIRINOX, more, because FOLFIRINOX is a very difficult chemotherapy to deliver, and we're just learning this, and you approximately would miss 40% patient or even a 45% patient, and they would never get the best possible chemotherapy. And gemcitabine based chemotherapy, if given a choice as passe, we will not offer them that. Having said that, do we have any evidence that we can deliver this so-called chemotherapy which should be given and cannot be delivered easily in adjuvant session? Can in adjuvant phase, can it be delivered at all in a neoadjuvant setting? So we'll start with some meta-analysis. There are at least 4 or 5 large big meta-analysis, and I have not taken up all of them, but this is a relatively large meta-analysis, and they could finish neoadjuvant treatment in 90%. This was gemcitabine and 5-FU. So this was achieved in approximately 65% in the previous data set, and it could achieve neoadjuvant treatment in 90%. So there is an increase 25% more ability to deliver the treatment, which is extremely important to them. The other meta-analysis also serve the same purpose. Most of these meta-analysis and subsequent trial have not shown decreased or zero resection rate. They have not shown increased morbidity or mortality, and most importantly, except for 1 or 2, they have not shown any increased fistula or leakage rate, which is one of the major concern of the surgeon about what will happen after the neoadjuvant treatment. So we'll start with whatever data we have. We don't have yet a phase 3 clear randomized trial, although current data set are going on. So this is a pre-op panc trial, which I believe is not about giving chemo before or chemo after. Most of the trials which have been completed are not total neoadjuvant trial, which is current flavor, and all the new trials are total neoadjuvant trial. But most of these trials are perioperative trial. Pre-op panc trial is more about radiation therapy, what it does if it is given before surgery, although there are 2 cycles of gemcitabine alone. So if you look at the totality of the trial and the update last year in ASCO 2021, there is a 27% improvement in overall survival. It doesn't show in median OS because the median OS is only 15 months. The curves start separating later on. I would actually start expecting the death to happen approximately 14 to 15 months after the patient has had successful surgery and chemotherapy. If you look at 5-year overall survival, there is tripling of the patient who is surviving. So upfront surgery followed by chemotherapy, only 6.5% patients are surviving with so-called modern gemcitabine. That's a very poor decimal result. We can offer them by giving this particular pre-op panc 2 trial data set and have a 20.5%, which is triplicating the overall survival over the next 5 years. The benefit was most commonly seen in a borderline resectable patient, and the benefit was not seen in resectable patient. I have my own hypothesis about it. My own hypothesis may be right or wrong. There was a large segment of this trial in which the patient were getting preoperative radiation therapy. The dose of systemic treatment was extremely low. I think 300 milligram per meter square of gemcitabine. I don't remember if sorry? Okay. So my assumption is, because the trial, most of the people who give radiation and chemo, gemcitabine is given at 300 milligram per meter square. Yes. So that time period during radiation, patient was not being covered systemically. So there is a possibility that metastasis had the chance to recur. This is my hypothesis why the resectable disease did not improve with the treatment, whereas a borderline resectable disease would improve because they got a higher chance of getting resection done. The benefit of radiation will be mostly locally, so therefore borderline resectable patient would benefit the most because they will have high resection rate, which would not be possible if they did not get radiation. That's entirely my hypothesis. So what about the trials which do not incorporate radiation? So if you look at the Japanese trial which gave gemcitabine and S1 is now available with us, and you can look at the curves, they start separating almost 3 or 4 months, a very early separation, and the curves don't mix and match. If you look at the overall survival, there is a 10 months improvement in overall survival. It's a phase 2 trial, and phase 3 could not be done because the advantage was good. And there was a 10% improvement in overall survival. These are not only statistically relevant, but this is a clinically meaningful improvement in patients' survival. Can we deliver the modern chemotherapy? Because gemcitabine with capecitabine or gemcitabine with S1 can no longer be called so-called current regimen. The current regimen will be either FOLFIRINOX or gemcitabine and nab-paclitaxel. This is not to compare the two arms. This was more like a feasibility for us, and they could show that a large majority of patients could be resected. So a modern chemotherapy regimen does not make resection impossible for surgeon. Approximately 73% to 75% managed to get the resection, and the other were not the primary endpoint, although there was some improvement in median overall survival, but I think this trial was not actually geared for that analysis. So there are two more trials with the modern regimen. This is in all ASCO 2022 this year. This is the German trial, and this time they used gemcitabine and nab-paclitaxel, which is the much easier chemotherapy regimen to use. Again, a phase 2 trial, and they could show that you can have a better node negativity, you can have a better R0 resection rate, which is amazingly 87.8%. This is very unusual of having an 87.8% resection rate compared to 67.4. There is an improvement by 7 months or 8 months of median overall survival, and there's a doubling of median disease-free survival, all meaningful values. There is a data set with PRODIGE 48, same group, French group, which brought in this chemotherapy in adjuvant and metastatic setting. It's a phase 2 trial. Arm 2 was FOLFOX was withdrawn, which is more so for a BRCA2 positive population, or BRCA1 for that matter. So one would focus on arm 1 and arm 2, and one would see that resection rates are good. There is within a year of trial data set, which is actually shorter for determining DFS and OS, because one would see more in 2 years, 3 years or 5 years, but one could already see the trend of improvement in overall survival, and one could see a 10% improvement in event-free survival. If this trend continues, there is a possibility that this will turn out to be another positive trial. Just to reiterate, we have moved on from 5-FU to FOLFIRINOX and gemcitabine, nab-paclitaxel. We would certainly not wish to give gemcitabine plus capecitabine. We would certainly wish to give FOLFIRINOX and gemcitabine, nab-paclitaxel, which is almost nigh impossible if you were to give it to a post-FAPL patient, at least at this point of time. One of the criticism could be that you can achieve excellent result in adjuvant setting by FOLFIRINOX, and you may not be able to achieve with the perioperative chemotherapy, but the criticism can be easily answered. The excellent result shown by adjuvant setting is because these patients have had the chance of undergoing resection, which doesn't happen often, or I wouldn't say often, to all. These patients had the chance to recover from surgery, did not develop metastasis, and these guys were fit for FOLFIRINOX. So that means you're sieving out the best possible patient, and in the best possible setting, FOLFIRINOX works much better than gemcitabine. In 2013, SEER data must have been updated. They showed that approximately 65% patients did not receive adjuvant therapy, a therapy which doubles 5-year survival from an adjuvant, no adjuvant treatment, is something which should not be the way we should think. So what is the level 1 evidence? Undoubtedly, the level 1 evidence is surgery, but there is now adequately collecting evidence that phase 2, phase 3 trials are showing that this is doable, feasible. There is no increased complication rates. There is no major decrease in surgical rates or no decrease in surgical rates. Tumor shrinkage happens. More patients have no negativity or path CR. More patients have R0 disease. In fact, there is some data saying that there is less fistula, and now there is some survival benefit. In fact, the trials are not going on about doing this or that. The trials entirely are going on about giving all chemotherapy before the surgery, vis-a-vis surgery after the chemo. And most of the groups in US are actually incorporating in a neoadjuvant setting radiation therapy as well. So that's the TNT approach, the way we treat some of the rectal carcinoma, of giving everything before pancreas. So Alliance trial and pre-op PANC3 will answer all these three key questions. Would I call it equipoise? I don't think so. Thank you.
For the invite. And at the outset, I'm very glad that Viraj made it very simple for me by keeping it operable pancreatic cancer. Otherwise, this debate would have been much messier. And most of my slides would be the same. It would be repetition, but I'll show the evidence from a different lens, the same slides. And again, I think this hall, there's a bias in terms of numbers with a lot of medical oncologists sitting around, but I do see a few familiar faces, few surgeons around, which is a moral booster. So we all know resectability, pancreatic cancer, 15-20% are upfront operable. We also know adjuvant chemotherapy improves survival. PRODIGE 224, it set the new gold standard. That is FOLFIRINOX adjuvant. That is the current gold standard in terms of the best survival outcomes that we see. Now, my colleague just before me, he pointed out these points supporting neoadjuvant chemotherapy. Theoretically, they all look very pretty. High rate of R0 resections, more completion of treatment. But remember, it requires both, it's a multimodality treatment that we are talking about, because pancreas is not about just completion of chemotherapy. It's more than that. So more completion of treatment, better patient selection for surgery, we'll discuss that, how it is, and early systemic exposure to micrometastasis. So I'll try to refute all these points one by one as we proceed further. Now, before even I start discussing those points, there's a problem while discussing this data in terms of the primary endpoints that we have chosen in the trials, namely R1, R0 resection. Now, reason being, these R0 rates are incomparable if we compare it across the surgical centers, because of the various reasons, like there is a divergence in pathology, specimen examination across the globe, and more so, there is no standard definition of R0 historically. Now it is evolving, but previously if we see the data, the R0 resection definition was variable, negative ink, tumor at ink margin, less than 1 mm, more than 1 mm. More so, when we talk about neoadjuvant therapy, we all know that the tumor does not necessarily shrink from the periphery, but it does spot-wise. And therefore, there is no clear, and we don't have any clear definition of R0, what is R0 after NACT. So all this makes it a bit problematic. And it is postulated that whatever we get this R0 margins, more R0 margins after NACT, it may be due to the reduction in density of the cancer cells rather than tumor shrinkage per se. So that is why this R0, R1 resection should be interpreted with caution. Now, rate of surgical resection, again, it does not make sense when we are talking about resectable pancreatic cancer. If at all, certain patients, they become unresectable while on neoadjuvant therapy. Now, this slide sums up the philosophy my dear friend was trying to push on you guys. I believe quota factory, everybody has seen that. And there's a famous line in that, अगर यहाँ आकर भी अगर यहाँ आके सिलेक्शन हो या ना हो, that is a different story. But अगर यहाँ आकर भी नहीं हुआ तो इसका तो होने ही नहीं वाला था. So the same thing my friend was trying to emphasize कि neoadjuvant chemotherapy helps in better selection of the patient. And अगर neoadjuvant chemo के बाद भी अगर if the patient does not go for surgery, that patient was not good enough to go for surgery anyhow. And then like he was trying to show good R0, R resection rates. I was just remembering how this old college days when we used to have this coaching classes where they used to just pick the good cases, the big good students, the ranker batches. And we never used to speak about the 99%, more than 99% of the people who never got into selection. But it always, that 1% was like a dream to all the parents and the students. Yeah, if they can do it, we can also do it. So that is the basic philosophy flaw when we discuss about this thing. So now coming to the evidence, now there's a lot of selection bias. Majority of the evidence, as my colleague has already discussed, it is retrospective and phase 2 data. Phase 3 data is coming up. And in many of the studies, borderline resectable pancreatic cancers have also been clubbed up. Also, there is no anatomical subdivision into pancreatic head, tail, or body, so which makes the interpretation even difficult. Now, let's start with selection bias. Now, the meta-analysis my friend showed was one side of the story. I'll show the same meta-analysis from the different side. Now, the problem is when we interpret this data, when we talk is resectable pancreatic cancer. That is when we are talking about it is per protocol analysis. We are not talking about intention to treat analysis. And that is the biggest problem in interpreting this data. Because many of these patients in these studies, even if you see this National Cancer Database, which is one of the biggest patient pool when we talk, which supports, and the data from that is cited as one of the evidence to support NACT. Many of these patients have actually not undergone surgery. This patients, if we see across various trials, this range varies from 20 to 40% that the patients, after going neoadjuvant chemotherapy, they don't undergo surgery. And that is why the data interpretation should be done with a caution. The only RCT which was published was prematurely stopped because of the poor accrual rate, 66 patients, and it did not show any significance, so R0 difference as well as survival rate. Now the same meta-analysis. Now what I'm going to show is two curves. You can see the upper thing, the diamond is more or less in the center. That is the intention to treat analysis. This is not working. This is intention to treat analysis. And if you see lower down, then it is favoring the neoadjuvant therapy, because that is the per protocol analysis. So that is how we play with statistics and try to prove our point of view. But in real world, what we want to see is not how many patients got treated. What we want to see is actually the survival outcomes. And this actual picture about survival outcomes can be given only if we look into the intention to treat analysis. So 14 studies in this meta-analysis, and overall survival benefit was only seen in patient who finished surgery also after neoadjuvant chemotherapy. And benefit was loss on intention to treat. So biological loss or loss of therapeutic window. So as I said previously, around 1/3 of patients, they don't come up to surgery. And is this rate acceptable? Some may counter argue, telling me, okay, 25%, it's a small number. But then I need to show the same, on the very next slide, the aspect 4 trial, when we compare the curves, the data curves, the 20% variation in the survival outcome is split as a very big difference. So why not this 20%? So obviously this 20% matters. So this patient not coming up for surgery. So completion of treatment, you can call it glass is half full or half empty, whatever way you wish like. And not, what we know is upfront surgery, not all will receive adjuvant chemotherapy. Neoadjuvant chemo, not all will receive surgery. So whatever the approach, not all patients are going to complete the treatment, that is local plus systemic. So as per the recent data, if we see, aspect 3, 90% of the patients, they finish their adjuvant therapy following surgery. And MD Anderson data, it showed 20% could not go to surgery after starting NACT. So I would say it's more or less balanced. So is the evidence enough to generalize? So for that, if you look only into the RCTs, meta-analysis of only the RCTs, 7 RCTs, the benefit was only seen in borderline resectable subgroup. In RCTs meta-analysis I'm talking about, and resectable subgroup, we did not find any benefit in terms of survival. Further complicating the problem is, how do we assess response to neoadjuvant chemotherapy? When we talk about breast, when we talk about colon, when we talk about rectum, we have well-defined criteria, how we assess response. But in terms of pancreatic cancer, as of now, the radiological downstaging is very rare, and therefore it is very difficult to correlate with survival and to predict how to interpret this response to neoadjuvant therapy. Even if we see the survival correlation with response to neoadjuvant chemotherapy, we all know there is a response to neoadjuvant therapy, and that is seen histologically also. But the PCR rates, it is very low, 2.5%. Most of the patients, they will be having stable disease, that is around 65 to 70% of the patients. So practically, if we see, there is no significant difference at all if we give neoadjuvant therapy, and that is also seen in terms of DFS and OS. There is no change in DFS and OS if we give neoadjuvant therapy. So delay in chemotherapy after surgery, that was one of the points my friend was trying to emphasize on. So whatever trials, adjuvant trials if we look into, most of the trials had an endpoint of starting chemotherapy by 12 weeks. So generally we don't have anything less than 12 weeks. So more or less we know if the chemotherapy should go in by 12 weeks. There was a retrospective data analysis of the aspect 3 data, which also showed chemo given before 12 weeks or up to 12 weeks. There was no significant change in DFS and OS. So we know till 12 weeks, if the chemotherapy is given, it is fine. What surprised me while I was preparing for this debate was there is actually a multi-institutional study which shows that even giving chemotherapy after 12 weeks also does not alter the DFS and OS. So does timing actually matter? Well, it's a single study, so I will take it with a pinch of salt. But still, we can keep this in mind that actually it's the giving of adjuvant therapy which matters, not the timing that much, probably. Now, my friend already spoke about all the problems which we have with neoadjuvant therapy. Neoadjuvant definition pancreatic cancer, we don't know which regime and how many cycles. Need for biopsy, which itself is a problem because you may require rebiopsy up to 20% of cases, which is again a problem. Biliary stenting, which causes a lot of problems. We know pancreatitis, cholangitis, stent occlusion, which can actually delay surgery as well as chemotherapy. So patient goes for neither of the two treatments, neither surgery nor chemotherapy. So we need to account for this patients also. Also, when these patients are jaundiced, obviously they'll require dose reduction also. So would we be able to give the actual dose which we actually aim to while giving neoadjuvant chemotherapy? That is a question which needs to be answered. What I feel is, what we are being driven towards is a solution bias. That is, we all want to find a solution because pancreatic cancer, we know there's not much of a headway in last 3 or 4 decades like many other solid tumors. So we are practically trying to push the systemic therapy as one of the tools to find out the best answers, that probably this will be the answer and solve our problem. And if we analyze this data carefully, RCTs of neoadjuvant therapy, the problem is there is different regimen when if we see the groups, one randomized to neoadjuvant therapy group and the adjuvant therapy group. So it makes it practically difficult to interpret whether it is the timing of therapy or it's the agents used which makes the difference. Second, if we see neoadjuvant therapy trials, invariably it comprises more agents and more effective agents. So again, the question comes whether it is the timing or it is the drug which we are using which makes the difference. And then very picking of data. Pre-OPANC trial, which I was not planning to talk much about, but since my friend highlighted this trial a lot, so I'll talk about it. Now the problem with pre-OPANC trial is the key outcome reported was R0 rate, that is 72% in neoadjuvant therapy group, 40% in upfront. However, 43% in neoadjuvant group did not undergo surgery, which was never accounted for and never highlighted when they published the results. More patients were having a poor performance status, 58% of the patients in neoadjuvant therapy group and 30% in upfront surgery group were actually ECOG 0. That is, 70% were less than ECOG 0 in upfront surgery and 40% in neoadjuvant therapy group. Higher rate of suspicious notes on imaging and higher CA 99.9 levels were there in the upfront surgery group. So with all these biases, how do we interpret the results? It's up to you. Now, pre-op 2 trial, yes, preliminary data, it supports it. But the point to note is, all the while we were talking about R0, R0, R0. But in this trial, R0 resection and morbidity rates are actually comparable between upfront surgery and NAT arm, which is in contrast to most of the other trials published at the same time. That is a NEPA-FOX RCT. Although we don't have the final complete trial results of this trial, and also now that S1 is available in India, but still we need to see how it works in an Indian population and the Western population. So this results, as of now, cannot be generalized for. So these are the ongoing trials which will give us the answer. Personalized care and precision oncology, you can never stay away from it. So it will also have a role to play in future. So for me, right now, NAT for resectable CA pancreas, the final words are yet to be written. As of now, the standard of care is upfront surgery with adjuvant chemotherapy. Personalized treatment would be the way forward. And this famous slides, India Shining, 2004, we all know. The same hoopla is all about neoadjuvant therapy, and we know what happened to this India Shining, 2004. Thank you.
The R0 definition will remain same for a surgery patient or a post-chemotherapy patient. I don't think it differs. Quota, well, all the randomized trial have all the quota patients. So they said quota 50 patient goes there and quota 50 patient goes there. They all reached quota. Okay, so you can't say that. So that is out. So, all the new trials, which 2 of them we did not show you next, and as Prodige 48, and including the Japanese trial, they had resectability criteria according to the current NCCN guideline. Yes, old meta-analysis is fraught with error. There is no doubt about it. Now that we have a randomized prospective, even if it is phase 2, and they're all according to NCCN, so I think R0 resection rate or the criteria for resectability, be it 180, be it 90, is no longer a criteria because these trials used all these things. Okay, you talked about poor accrual. Actually, some of the trials did not accrue because surgeons did not want to accrue the patient to neoadjuvant chemotherapy. It's a standard thing. Radiation people will realize lung carcinoma 2 centimeters has taken them decades to prove that SBRT is okay. 1, 2 trials for not accrued, because the data set showed the neoadjuvant chemotherapy is doing better, and the ethics committee said you can't continue, stop the trial. Okay? Never said surgery should not be done. Never said so. Okay, you said no sir, chemo, no surgery. We can't survive without surgeons and radiation oncologists. Okay, you talked about aspect 4, 20% did not go surgery. That was adjuvant trial. Patient underwent surgery first. Okay. Okay, fine. So the new trials are prospective. 2 of these trials have not been shown. Meta-analysis retrospective, I did not focus because unless and until we have prospective trial, we rely on retrospective data. But once we start having prospective trial, we consider them redundant and we start saying about prospective trial. In absence, yes, we do. Residual tumor, how do you define that? I don't give a damn because the patient will undergo surgery. And the surgical detail will define what is the pathological response. I don't care whether the MR showed response or not. Now, the issue is not whether you give chemotherapy within 12 weeks or not. I agree, 12 weeks is fine. Issue is you are not able to offer chemotherapy. You're never able to offer chemotherapy to 1/3 of the patient. Patient refuses. They come on a wheelchair. Alternative biopsy, I agree, biopsy is an issue. The new NACT trial people have brought in a 90% sensitive and specific, yet not proven, whereby they're doing a ctDNA, they're doing a CA19.9 and thrombospondin, and 90% of time they can predict, yet not there. But the future may happen that you may not need biopsy in the patients you are not able to achieve tissue, and you may get away, but it is too early. Dose reduction, yes, jaundice patient required dose reduction, but all these patients with the chemotherapy had the dose reduction, and despite that they showed advantage. Imagine if they did not have to reduce the dose, then the upper curve would have gone through the sky.
Yes, Nitin.
So nobody said no for chemotherapy. As you said, nobody said no for surgery. We all are there to stay together. It's basically what we are discussing is presently what is the status. So presently, what again I would maintain is, as of now, neoadjuvant therapy for resectable pancreas cancer is not the standard of care. In future, nobody knows, even I don't know. In future, maybe we both are standing on the same side of the table supporting it. But as of now, neoadjuvant therapy is not the standard of care for resectable pancreatic cancer for the reasons I mentioned. And when you discuss about this R0 section, actually there's a paper which I did not show, in which the interpretation of margins after NACT, it's a difficulty. R0 and R1 resection, there's a difficulty in that. So that is why I brought out this point that this R0 and R1 resection, what we talk about a lot as a surrogate marker when we talk about neoadjuvant trials, is actually a big fraud marker when we talk about resectable pancreatic cancer. So it should be interpreted with caution. And chemotherapy, as I started with my presentation, it's a multimodality treatment. Everything is going to be there. Radiation is also going to have its say. Maybe in coming years, maybe the next trial would be, I would be fighting against a radiation oncologist to defend my thing, whether radiation is required or not. But all said and done, as of now, resectable pancreatic cancer, adjuvant chemotherapy after surgery, because the numbers what you pointed out, 20% don't go for chemotherapy, same 30% they don't go for surgery also. So either way you see it, it's the same.
I just have one comment to make. A very good attempt, Nitin, and very good debate. But you must understand, even in the resectable, when we call it, there is a range, you know. So there could be just tumor, which is just a nice small tumor, which is away from the vein and the artery. But there could be a less than 180 degree, which comes under resectable, but the tumor is touching the vessel. So I think these are the particular group which may require chemotherapy and which will help. And of course, giving the new adjuvant. So we are conducting a randomized trial, phase 2 NEVAS trial, where we are randomizing these patients into upfront surgery versus we are giving neoadjuvant chemotherapy and SBRT also in the other one. And we see that yes, a few of the patients are progressing and they don't go for surgery. And it really burns the heart of a surgeon. But these are the very same patients that when you operate, they are going to show up with mets within 3 or 4 months or 6 months. So it's the neoadjuvant, the whole philosophy of neoadjuvant is you spare them of unnecessary surgery because they have already have micrometastasis already sitting. So that's why they are showing up mets very early. So you are sparing them of surgery. So surgery is not improving outcomes. See, overall survival, they have to survive also.
Agreed. And my only thing is over here, because it's a bias, the numbers as I said to start with only. As a surgeon, why only surgery is unnecessary? Why not chemotherapy and radiation
I think
unnecessary?
somewhere along the line,
No,
at
no,
some,
chemotherapy surgery is a very, very morbid surgery, and it's not. No, no, no. I don't agree.
I think
So
somewhere along the line we have to find some middle path there.
yes,
When we
so
talk
we have
about
to
borderline
properly
resectable
select
pancreatic
patients.
cancer, where we know that the chance of having a R1 resection is going to be very high, that's a subgroup of patients.
Yes.
It is definitely going to be much more easier to convince everybody around that some
Correct.
neoadjuvant therapy is going to be the way forward. When it comes down to resectable pancreatic cancer, I think somewhere along the line, some middle grounds have to be found wherein we know that these patients are going to fail. They are at a much higher risk of
High
failure.
risk.
And I think somewhere along the line, factoring in a lot of other things rather than just the definition of it
CA
being a resectable.
99 level
The
for
CA99
that matter.
Yes,
Yeah.
CA99, the NCCN, yes, yeah. So
CA 99
NCCN
vessel
guidelines, when
abutment.
it talks about high risk group, it talks about in that high risk group there is a CA99 more than
Yes.
1,000 there. So that is something which we also have
I
to factor in
totally
somewhere when we are
agree.
talking about
Yeah,
resectable pancreatic
yeah,
cancer. That's
yeah,
important for
yeah.
us to understand.
Thank you. So I guess you all must have heard it. चमन में एक तलाते रंगबू से बात बनती है हम ही हम हैं तो क्या हम हैं तुम ही तुम हो तो क्या तुम हो basically very soon we'll be having all these answers ki which particular subgroup of even resectable cancer may get benefit of doing going ahead with neoadjuvant chemotherapy or neoadjuvant chemoradiation or which subgroup of patient will have benefit from surgery. Dr. Shailesh Khande sir from TMH Mumbai is online and he is listening to us. Sir, your expert comment on this debate, sir.
You want my expert comments? You know, Reena works with me every day, and I also see the gentleman discussing. I think it's very clear. In terms of the highest levels of evidence available, it's very obvious that for resectable disease, we still have upfront surgery as the standard of care. Yes, the surgery is morbid. You will have worldwide figures of 30% complication rate, and you will have less than 3% mortality rate. Having said that, good surgery results in up to 70% of patients getting adjuvant treatment as well. So, in a pure, simple resectable disease, which is away from the critical blood vessels, whether it's a periamp or whether it's a pancreatic ductal adenocarcinoma, barring some people in the United States, there is a near unanimous understanding that surgery is still the best way forward. First, with good adjuvant treatment, as shown by the Prodigy trial. I also heard what Reena said, and she's right, that when you have a bulky tumor, which is close to a blood vessel, not involving it, so it is also resectable, but this is the extreme end of the spectrum of resectable, or let's say it is the pre-borderline resectable tumor. That's where the controversy is, and rightly so, because the incidence of R1 resection tends to go up, and we want to offer the best oncologic benefit to the patient. So in those cases, you will have to decide on a case-to-case basis, and there would be a number of them who would go for a neoadjuvant approach. So this is where I would like to stop my thoughts